Good morning, everyone. My name is Reese. I'm one of the young people facilitators at YACVic, and we'll get started very shortly. I can see that most of our attendees are joining now, which is fantastic. So the webinar today will go for 90 minutes, with the first 60 minutes dedicated to presentations, and the final 30 minutes reserved for questions and discussion with the audience. Attendees are welcome to attend either the full 90 minutes or just the first 60 minutes if you would like. So I'd like to begin by acknowledging country. I am calling in from Wurundjeri Bunurong country from the Kulin Nations, and I'd like to pay my respects to elders past and present, and any Indigenous or Torres Strait Islander people who are in the call today. And I'd like to extend a particular acknowledgement to any First Nations young people who may be joining, because this is a youth-focused webinar, of course. So just a reminder that this webinar is a part of the Youth Mental Health Community of Practice, co-convened by Orygen and YACVic. The community of practice brings together a network of young people and those who support them to learn about and drive change in key policy and practice areas of the youth mental health system. The community of practice holds regular events to share information, facilitate learning, and create connections across the youth mental health sector, as well as other sectors that have a role to play in supporting the mental health of Victoria's young people. If you are interested in joining this community of practice, there will be an invitation sent to you via email following this meeting. So in general, this webinar is about a brief reaction and overview of the Royal Commission final report that was handed down last week. For many of us, it's transformational, and it is a roadmap to better outcomes for young people in the future. So before we get started, if you have comments or questions for the presenters, please use the Q&A function at the bottom of your Zoom window, and I will read those questions out at the end of the presentations. So I will move to our first speaker now. Our first presenter today is Vivian Brown, and Viv is the Associate Director of Government Relations and Policy at Orygen, a role in which she oversees Orygen's government relations, advocacy and policy work. Today, Viv will be providing an overview of the scope and purpose of the Royal Commission, as well as a high-level overview of the new service system and an overview of the youth-specific recommendations. So I'll hand over to Viv now. Good luck.
Thanks so much, Reese. I really appreciate that introduction, and thanks to everyone for coming along this morning. So my presentation is going to take us back just quickly in the beginning to how this all came about. So in the 2018 Victorian government election lead-up, the Premier, Daniel Andrews, made an announcement in Shepparton at a men's shed. In that announcement, he said that he had been listening to the voices of mental health advocates and consumers who were telling him that the system was catastrophically failing them. He agreed with them and made statements that the system he believed was broken, and committed the Labor government, should they be returned after the next election, to hold a Royal Commission into Victoria's mental health system. So why is that so important? Well, the Royal Commission is actually the highest form of inquiry available to government. They're independent of government. And you'll notice more and more we see governments utilising the Royal Commission process as a way to really forensically examine issues, whether they be with particular entities or with a system, and utilise those processes to really drive reforms and change going forward. So they have broad powers. They can compel individuals to provide evidence under oath, and can hold public hearings, public consultations, and undertake in-depth research and analysis to understand the issue and form recommendations about what needs to change. It's important to note that recommendations from Royal Commissions aren't always implemented in full, but this is where the Victorian Royal Commission does differ, in that the Victorian government, even before it knew what the recommendations were going to be, said it was going to deliver and implement all of the recommendations coming out of this process. And this particular Royal Commission had a focus too on identifying and solving system-wide issues rather than looking at individual cases or incidences. So the process took over 2 years. We had an interim report delivered back in November 2019. At that point, we'd already had over 8,000 contributions into the process. So by the time the final report was delivered, there were over 12,000 people, individuals, services who had contributed input into the Royal Commission. It's a very, very big report, runs over 3,000 pages in 5 volumes. And in addition to the 9 recommendations that were in the interim report, we have another 65 recommendations now that the government has committed to implement. So the Royal Commission identified a number of critical issues in their work, one being an insufficient level of political and policy attention to mental health, which had actually meant that it had become deprioritised within the health system. In deprioritising it, we actually saw the flow-on effects in terms of inadequate investment, so that had resulted in an under-resourced, overworked and crisis-driven mental health system and workforce. It found that the system was inequitable and poorly integrated, and also provided quite a lot of commentary on how families, carers and supporters had not been engaged in the care and treatment of the people that they loved, and they were actually unable to access supports for themselves for their own needs. The Royal Commission validated the existence of the missing middle. And I've just taken this graph from the executive summary, which highlights just the extent of the missing middle, even within our specialist services. So over on the right-hand side, you can see that the Royal Commission found even over 95,000 Victorians who needed specialist or tertiary care were currently not getting services within the private or the public systems. I just wanted to touch on here a number of key themes that I thought emerged from the report. One of them being the need to prioritise and elevate and listen to the lived experience in designing and delivering mental health services into the future. They identified there was a need to improve access right across the board, but particularly for diverse population groups that were missing out or had particular needs. So that included multicultural populations, rural and regional populations, and LGBTIQA+ populations. They saw research and innovation as being key to driving a better mental health system in the future, and focused on leadership and accountability. So on that point, a number of the recommendations in the report are going to hold the system accountable into the future. So these are quite dramatic and transformational shifts. There's a new Mental Health and Wellbeing Act that will be developed, a new outcomes framework that will be reported against annually, and we're going to have a new subcommittee of Cabinet that's chaired by the Premier for at least 2 years. There's also going to be an establishment of an independent and statutory Mental Health and Wellbeing Commission that we don't currently have in Victoria. So in terms of some service system reforms, there's going to be a new system for governance and commissioning. So where previously we had services commissioned or contracted, particularly state services through local health networks, that will be transformed into 8 regional areas and 8 regional mental health and wellbeing boards who will be responsible for planning, contracting and commissioning the local and the area mental health services in the future. It's going to take a bit of time. So they're expecting this to be in place sometime between 2023 and 26. So in the interim, there'll be these interim multi-agency advisory panels established in each region to support the Department of Health. The system's going to be delivered across 6 levels now and across 2 different age streams. So there'll be a 0 to 25-year-old infant, child and youth mental health and wellbeing stream, and an adult and older adult stream for those aged 26 and over. And the idea here across these 6 streams is to provide Victorians with a step up, step down model of care across the community and into local community health services and more specialist services. So just honing in on what it means for the youth mental health system. So the Royal Commission found that the average amount of treatment that young people were currently receiving in the CAMS and KIMS service system that we had in Victoria was widely variable. So they recommended the need for this 0 to 25-year-old system to provide age and developmentally appropriate treatment, care and support. In terms of what that system looks like for across the 6 levels, we have, I'll actually let Luke and others from YACVic talk a bit more about those first 3 levels, from family and informal supports through to primary and secondary mental health related services. What I just want to focus on today is having a look at the local mental health and wellbeing services stream and the area mental health and wellbeing services streams. So looking at the local mental health services, these are anticipated to respond to a large amount of the current demand that we've got on our CAMS and KIMS services at the moment. And the Royal Commission said that they saw headspace centres being the providers of these supports, although over time you may see other providers coming into the mix. These local mental health and wellbeing services are going to deliver treatments and therapies, including integrated care for substance use, wellbeing support, so including a focus on study, employment, housing needs, education, peer support and self-help, and care planning and coordination. So it's quite a big component of the system going forward. The area mental health and wellbeing services, we divided across an infant, child and family stream for 0 to 11-year-olds, and then a youth area mental health and wellbeing service stream for 12 to 25-year-olds, all the way up to the 26th birthday. But it's important to note that this will still be applied flexibly. So at 26 years of age, services need to work in partnership with young people and their families to decide on where they want to transition into the adult system. There'll be no more rigid geographic boundaries, and these services are going to be delivered by a health service or a hospital in partnership with a non-government organisation, particularly around the psychosocial supports. These services are going to deliver everything that the local area mental health services deliver, but at a higher intensity of care and support. They're going to provide more outreach, expanded hours of care and mobile services, and you'll see these services also employ up to 3 trauma specialists in every one of the infant, child and youth area mental health services. As I said, they're going to be delivered across 13 sort of areas in Victoria, although there are no catchments, but these generally fit to the current CAMS and KIMS services, apart from a little bit of a shift in the southeast. In terms of integrating these services, the Royal Commission has identified there'll be a need to set up formal partnerships to step up and step down care between the headspace centres and the area mental health and wellbeing services. The Victorian government's going to have to work with the Commonwealth to agree on how this happens. And they're also going to have to work with the Commonwealth government, Headspace National and the primary health networks to see whether the infant and child and youth area mental health and wellbeing services can become the preferred providers of Headspace as well, so fully integrated. There are some recommendations as well looking at crisis responses and safe spaces. So a new 24 hours a day telephone telehealth crisis line for all ages. But also importantly, they're setting up safe spaces and facilities for mental health and suicide crisis. And 4 of these safe spaces are going to be specifically for and co-designed with young people. And finally, I just wanted to touch on a number of statewide services that will be implemented from the Royal Commission. So these ones are new ones. There's going to be a new statewide trauma service, an expansion of existing specialist for youth forensic services, and a statewide specialist service for substance use and addiction and mental health issues. So I think that that's it for me at the moment. I'm just going to go up and stop sharing my screen and hand over back to Reese.
Awesome. Thank you, Viv. Just as a quick reminder to everyone that this webinar is being recorded and it will be made available after this event. Feel free to use the chat function if you have any general comments during the presentations. And just another reminder to feel free to use the Q&A function throughout. I see that we have our first question, which will be the first question asked after the presentations. So moving on to our next presenter, we have Luke, who is the Policy Manager at YACVic, and he will be speaking to some additional recommendations on the topics of prevention and promotion, stigma, and communities. Over to you, Luke.
Thanks, Reese, and hi everyone. I use he, him pronouns, and as Reese said, I'm going to be speaking about prevention and promotion, some of the other recommendations that were included by the Royal Commission, including around stigma and discrimination, and then the community responses, as Viv alluded to. Part of the reason we're speaking about these things is through our consultations of both YACVic and Orygen, we've heard from young people, the youth sector and the community sectors, that they want specific things that might not be seen as youth-related recommendations, but are really, really important to both young people and to those sectors. And that's why we're going to discuss them here today. So the first one that I want to touch on is prevention and promotion. And the Royal Commission said that at the heart of their reforms is a vision for a mental health and wellbeing system that fundamentally shifts its focus towards promoting and delivering really good mental health and wellbeing. They said that social and community services are really good potential sites for prevention and promotion, and specifically referenced housing, justice, aged care, family violence, and youth services, and said they could all play a more effective role in mental health promotion. So the recommendation that the Royal Commission has made is under recommendation 2, and it's to establish a mental health wellbeing promotion office to develop and coordinate a statewide approach to the promotion of good mental health and the prevention of mental illness. There's a really good table on page 178 in volume 1 of the report that goes through the functions of that new office. The office will be led by a mental health and wellbeing promotion advisor who will report directly to the Chief Officer for Mental Health and Wellbeing Office that we've reported. They will lead development and delivery of a whole of government statewide plan for the promotion of good mental health and wellbeing and the prevention of mental illness. And this one's really important because it's going to provide a really long-term approach to promoting good mental health. It's going to distribute dedicated funding for the prevention programs and initiatives right across the state, and they're going to lead public health promotion and communication strategies. They're also going to do some work around monitoring outcomes and evaluation, and then supporting mental health and promotion activities specifically for diverse communities right across Victoria. I really want to highlight the statewide plan. They said that the development of a new plan is intended to strengthen mental health promotion right across all settings and sectors that are outside of the mental health and wellbeing system. So we see this as a really, really important step in promoting good mental health right across the state and doing that real universal work that isn't currently captured, and the Commission themselves acknowledged wasn't done strategically and in a broad sense right across the community. The other area that I want to touch on is stigma and discrimination. The Royal Commission were really blunt in their analysis of stigma here in Victoria. They said that as a community, we have struggled to understand or be compassionate about lived experience of mental illness. And this has meant that people with lived experience of mental illness have been excluded from society. They said that structural reform is needed. And they also highlighted that some Victorian communities and people experiencing intersectionality face multiple forms of stigma and discrimination. They said that Aboriginal and Torres Strait Islander people, LGBTIQA+ people, those from culturally and linguistically diverse backgrounds, those who are deaf or hard of hearing, refugees and asylum seekers, and people with dual disabilities are subjected to intersectional discrimination, and really saw that existing strategies to reduce stigma right across a number of areas haven't materially shifted attitudes. So they were quite honest in their appraisal of current initiatives to address stigma. So they recommended under recommendation 41 that the Mental Health and Wellbeing Commission work with a network of partners, including research organisations, to lead the design and delivery of anti-stigma programs. Really importantly, they said these programs will continue on a long-term basis with long-term funding, And they emphasise that this should apply in some specific settings across the whole state, but they identified healthcare settings, so primary healthcare and hospitals, workplaces and schools, all types of schools, primary, secondary and tertiary, as really important places where stigma has to be addressed, and these programs will be particularly delivered to. They've also recommended a grants program to support community-led organisations and individuals to deliver projects that challenge stigma and essentially improve views about stigma, mental health and wellbeing right across the spectrum and right across the state. The Commission also made a number of recommendations about discrimination, particularly empowering 1 or 2 independent legal services to work with people with lived experience of mental illness to initiate legal claims, including test cases, to essentially improve mechanisms to address systemic issues of mental health discrimination in Victoria. I also want to touch on a few other recommendations related to stigma that were in other areas, because I think it's really important. In the workforce recommendations under recommendation 16.1b, the Commission said that they should promote inclusive workplaces that are free from stigma and discrimination. And for schools under recommendation 17.1, they said that there should be funding for evidence-informed initiatives, including anti-stigma and anti-bullying programs to assist schools in supporting students' mental health and wellbeing. So while the Commission has acknowledged that addressing stigma is going to be a really difficult task, they have set up a really solid background and solid foundation on which to create anti-stigma programs and begin the work to do that real communication, research and long-term work to address stigma here in Victoria related to mental ill health. We also heard from young people and communities, youth workers and mental health workers when we conducted our own consultations related to the Royal Commission that the work of community is really, really important. And we heard that community members want to have a really active role in supporting good mental health. The Commission also acknowledged this and said that they had witnessed firsthand the drive, passion and capability of community members to create change at the local level. And they recognised that community members across the state had the aspiration to do more to improve mental health and wellbeing. I think they've made a number of recommendations, as Viv has alluded to, about regional boards that are clearly going to improve and create a space for community members to have a say in the governance of the new mental health system. But there are some other specific things that I want to touch on that go to the role of community members in some specific recommendations. The first is the community collectives. They are collectives that will be established to support community activities that promote social connection and inclusion. There'll be a new community collective in each of the 79 local government areas right across the state, and they will be resourced and supported to test and develop a range of initiatives that promote community participation, inclusion and connection. The Commission have said that they will specifically consult with local communities, identify community need, decide what projects to fund, support sustainability, and then align with municipal planning and the work of local government. So this seems like a really novel and interesting approach to embedding community responses and community members in the design and work of the new mental health system and ensuring that communities have a say in locally developed projects. I want to quickly touch on this diagram from the report, which shows the Commission's intended makeup, composition of those collectives. I think the really important thing that I'm seeing here is in the top middle row, you can see that young community members are specifically identified as being important parts of that community collective. And it's our hope that given this diagram and the recommendations of the Royal Commission, that young people will be included in these community collectives as a key part. I also want to touch on some of the other little parts of these community collective ideas that I think are really important. Firstly, that community members should be remunerated for their time and the contribution they make to the collectives. As many of you here will know, including remuneration for people to be involved and recognising their lived experience through payment and reimbursement is really important. They've also said that the relevant body will provide annual ongoing funding for each of the community collectives, and they'll also have staffing equivalent to 1 FTE for each community collective to coordinate and provide support and ensure that those activities happen. I'm also going to quickly touch on one other idea that's really important and part of this support that will be provided to communities. And I'm sure Dave will touch on this later around suicide prevention. But the Commission have also recommended gatekeeper training be made available online and free to all adults in Victoria. The Commission acknowledged that suicide prevention and response requires a community-wide approach where everyone has a role to play. And the Commission acknowledged that community gatekeepers are members of the community who may come into contact with people who are experiencing suicidal behaviour. They specifically highlighted sports coaches, youth workers, school and higher education teachers, retail and hospitality workers as people who are considered gatekeepers. That's not necessarily the language that we have used at YACVic in the past for describing these types of community leaders and persons who can provide assistance, but the Commission have acknowledged the role that they play, and under recommendation 27, they've recommended providing free, online, evidence-informed community gatekeeper training for Victorians to develop suicide awareness and prevention skills. They've also recommended, under that same recommendation, that Aboriginal people be allowed to design culturally safe community gatekeeper training for Aboriginal people in the Victorian community. And so there you can see they're clearly going towards those roles that communities play in promoting good mental health and supporting in suicide prevention efforts. I'm now going to hand back to Reese, but I look forward to reading all of your questions.
Awesome. Thank you, Luke. So we'll move on to our next speaker now, Julia. Julia is a policy officer at YACVic, and she will speak to the more specific recommendations on Aboriginal and Torres Strait Islander communities, diverse communities more generally, and also recommendations in terms of education. You have the floor, Julia.
Thanks, Reese. Good morning, everyone. I'm Julia and I use she, her pronouns. So like Reese said, I'm going to be talking about some specific recommendations related to specific cohorts, as well as what some of the recommendations are related to the education system. So to begin with, the Royal Commission did some targeted consultations with various community groups, including with Aboriginal and Torres Strait Islander communities. Organisations such as the Victorian Aboriginal Community Controlled Health Organisation had the opportunity to submit reports to the Royal Commission where they explored the impact of the mental health system on Aboriginal and Torres Strait Islander people. Some of the key findings through the research were that culturally safe services are not always available to Aboriginal and Torres Strait Islander communities in Victoria. Aboriginal and Torres Strait Islander communities continue to live with the effects of trauma connected to colonisation and post-invasion government activity, such as policies that gave rise to the stolen generation. Everyday stresses associated with social marginalisation can have pervasive negative effects on Aboriginal and Torres Strait Islander people. And the data suggests that depression and anxiety are more prevalent among Aboriginal and Torres Strait Islander people compared to non-Aboriginal people. The report also acknowledged that some groups face further barriers to accessing treatment, care and support when experiencing mental illness or psychological distress, and among them were Aboriginal and Torres Strait Islander people. The report attempts to address this through their recommendations. So recommendation 33 is specific to supporting Aboriginal social and emotional wellbeing. The Royal Commission recommends that the Victorian Government builds on the interim report's recommendation 4 to support Aboriginal social and emotional wellbeing and resource the Social and Emotional Wellbeing Centre to establish 2 co-designed healing centres. Resource infant, child and youth area mental health and wellbeing services to support Aboriginal community-controlled health organisations by providing primary consultation, secondary consultation and shared care. Resource Aboriginal community-controlled health organisations to commission the delivery of culturally appropriate, family-oriented social and emotional wellbeing services for children and young people. And resource the Victorian Aboriginal community-controlled health organisation in partnership with an infant, child and youth area mental health and wellbeing service to design and establish a culturally appropriate, family-oriented service for infants and children who require intensive social and emotional wellbeing supports. Recommendation 27 was more broadly around facilitating suicide prevention and response initiatives, but there was a specific point within that recommendation to build on the interim report's recommendations to develop initiatives to support people experiencing suicidal behaviour, including enabling Aboriginal people to design culturally safe community gatekeeper training for Aboriginal people. So the Royal Commission also did targeted consultations with other community groups, including with culturally diverse communities, LGBTQIA+ communities and disabled communities to inform their recommendations. It was recognised in the report that these groups will face sometimes additional barriers, with additional factors shaping the experiences of some people living with mental illness or psychological distress. So this again will include LGBTQIA+ people, refugees, asylum seekers, people from culturally diverse backgrounds, and people living with disability. People from these groups can face a range of barriers when seeking treatment, care and support. For example, the mental health system does not currently deliver safe, responsive or inclusive care for many people from diverse communities and social groups, and that was recognised in the report. The report outlines a need to work in partnership with Victoria's diverse communities and set new expectations for services to be more inclusive, ensuring the needs of Victoria's diverse communities are met. So for example, support for LGBTQIA+ people to navigate and access the system should be strengthened, and Victorians should be able to obtain appropriate mental health information regardless of first or preferred language, hearing, literacy or neurocognitive ability. Recommendation 34 was specific to working in partnership with improving accessibility for diverse communities. This included ensuring the active engagement of Victoria's diverse communities throughout the process of planning, implementing and managing the reformed mental health and wellbeing system. Legislatively providing that the Secretary of the Department of Health is responsible for the delivery of a mental health and wellbeing system that responds to the needs of Victoria's diverse communities and promoting access and equity of outcomes. Ensuring that the Mental Health and Wellbeing Division collects, analyses and reports on data on the mental health and wellbeing of Victoria's diverse communities for planning and funding purposes and to improve transparency in mental health and wellbeing outcomes for diverse communities. Ensuring that Victorians, regardless of first or preferred language, hearing, literacy or neurocognitive ability, have access to appropriate mental health and wellbeing information and means of communication throughout the system. And enabling Victoria's diverse communities and community-led organisations to design and deliver mental health and wellbeing information and awareness campaigns and assist their communities to navigate the mental health and wellbeing system. There was also the added recommendation that by the end of 2021, the government should provide recurrent funding to Switchboard Victoria to deliver its Rainbow Door program at scale to support people who identify as lesbian, gay, bisexual, trans and gender diverse, intersex, queer and questioning to navigate and access the mental health and wellbeing system. And there was a final recommendation to enable the development of digital technologies to support the delivery of language services that assist access to and engagement with mental health and wellbeing services for diverse communities. So education is mentioned in the report in a variety of contexts, particularly regarding the ability of education institutions such as early childhood care, schools, TAFEs and universities to support young people experiencing mental illness or psychological distress, as well as considering the level of education and training required for practitioners, community gatekeepers and frontline workers in adequately supporting people seeking treatment and care for their social and emotional wellbeing. A key finding in the report is that communities and places do not adequately support good mental health and wellbeing. Currently, there's a predominant focus on the mental health system, meaning that the social factors influencing mental health and wellbeing are not recognised. This focus also downplays the importance of communities, workplaces and education settings in shaping good mental health and wellbeing. It was also noted that younger people can experience mental illness just as they are seeking to participate in higher education, and collaboration across governments and the education sector will be vital in responding to the varied factors that shape people's mental health and wellbeing. So the Commission's recommendations for education settings focus on primary and secondary schools. The report noted that there's a strong potential for other education settings, such as early childhood and university settings, to support mental health and wellbeing, but based on the evidence, the Commission concluded that the highest unmet need is in primary and secondary schools. And I will add, there are no specific recommendations around education, but there's a lot of text in chapter 11, I think, but I will double check that for you, around I guess, the recommendations regarding education settings. So it's not listed within the 63 recommendations. Basically what the report outlines is that it promotes the idea that all Victorian education settings should be supported to play a positive role in promoting mental health and wellbeing for all members of their community. As part of this vision, schools should play a stronger role in promoting good mental health and wellbeing, and school leaders and staff need to have a clear understanding of how their role complements those of many other settings and services which support mental health and wellbeing, and they need the resources to be able to fulfill that role. Young people who spoke directly to the Commission highlighted the role of education settings in supporting their mental health. They identified the need for mental health and wellbeing education for school-age children and consistent check-ins to support early intervention. It was identified that education settings may have a more critical role in areas where treatment, care and support options are limited, such as in rural and regional areas. The accountability of tertiary education providers should be strengthened with expanded mental health support to their students, including international students. And there was some recommendations that universities should work closely with multicultural and ethno-specific community-led organisations in order to support inreach into universities to engage with international students. And finally, the Commission suggests that the Victorian Government identifies the minimum level of service that each TAFE should provide to inform future allocation of community services funding. So on education, this is a table that has been pulled from the report, which outlines some of the initiatives that are already happening within the education system in schools. These are developed by both the Commonwealth and Victorian governments, as well as non-government organisations. So this is a snapshot, it's not an exhaustive list. And there are many other programs that seek to support mental health and wellbeing as either a primary or secondary aim. The report does speak to the fact that mental health and wellbeing is a discrete focus area within the social and community health section of the Victorian school curriculum, predominantly for years 3 to 10 in school. And the curriculum has other relevant focus areas such as alcohol and other drugs, health benefits of physical activity and relationships and sexuality, which contribute to students' understanding of the broader influences on mental health. So whilst many areas of the Victorian curriculum are designed to support good mental health outcomes, the recommendations in the report are focused on strengthening and improving this. So thank you very much, everyone. I will pass back to Reese.
Awesome. Thank you, Julia. I see that we've had a few comments in the chat, which is fantastic. So now what I'm going to do, instead of handing to one single speaker, I'm going to hand to 3 speakers. I'll let you know which order they're coming in. So the first we'll have Jen, who will speak to rural and regional communities, and then Emily, who will speak to lived experience, and Mark, who will speak to stigma and diverse communities. And I'll let each panelist introduce themselves and hand to the next speaker as well. So to you, Jen.
Thanks, Reese. Jen speaking. Hi, everyone. I'm Jen. I use she, her pronouns, and I am the lead facilitator at YACVic. And yeah, thank you so much for having me here today. So as Reese said, I'm going to speak a little bit to rural and regional access, I suppose. The reconstruction of Victoria's mental health system was so needed, and it's so great to see that the recommendations ensure young people will receive a lot more support than what they're currently getting. It's particularly great to see that young people will be better placed to access services closer to their communities, because we know that access has always been an issue for rural young people like myself. I forgot to mention that at the start, but I am a rural young person. I am from the beautiful Great South Coast, really close to the 12 Apostles down there, which is a beautiful part of Victoria. The issues around rural and remote access to mental health services are complex because the problems we face are so unique. Who knew that public transport would come into conversations about mental health? Well, every rural kid did actually, because we live the geographic isolation every day. In my own hometown, the nearest Headspace centre is an hour away, and with working parents and very limited public transport options, accessing the services available at Headspace are near impossible. Not to mention the service system in general can be confusing. In fact, I think it would be understandable if young people from small towns weren't aware of mental health services in their areas, because it is difficult to know who was eligible for what and how to navigate who was responsible for what. Mental health professionals such as psychologists and psychiatrists are hard to come by in these very rural areas because often funding for outreach or visiting services are limited. These are just a few of the issues facing young people when it comes to accessing support in rural areas. However, I am so pleased to see the Royal Commission have addressed these unique issues to support the mental health and wellbeing of young people in rural and regional Victoria. Recommendation 4 will see the creation of 8 regional mental health and wellbeing boards who will commission mental health and wellbeing services. This reconfiguration of rural and regional mental health will also be bolstered by a strong focus on rural healthcare workforce and recruitment and retainment schemes. Recommendation 39 places focus on supporting the mental health and wellbeing of people in rural and regional Victoria, and mentions not only providing additional resources to enable mental health services to operate in small or geographically isolated communities, but also mentions the trial of 2 new digital service delivery initiatives in rural and regional areas by the end of 2022. And recommendation 40 talks about providing incentives for the mental health and wellbeing workforce in rural and regional areas. The Royal Commission recommends that the Victorian Government address mental health and wellbeing workforce supply needs in rural and regional areas and establish an incentive scheme to attract mental health and wellbeing workers to rural and regional mental health and wellbeing services and retain mental health and wellbeing workers in such services. As a person who has been unemployed twice for lengthy periods of time since I moved back to my small hometown in 2018, I am particularly happy to hear about this one. I have many feelings about the future of Victoria's mental health system, but I think the most overwhelming thing that I'm feeling is relief. And I say that as I let out a sigh of relief, because actually these recommendations have probably exceeded my expectations, in all honesty. These changes have been a long time coming, and I want to take a moment to acknowledge the lived experience in the room right now and the value of lived experience that has gone into this incredibly huge body of work. I am feeling quite positive about the future of our mental health system, and I hope that young people across the state do too. And now, speaking of lived experience, I'm going to hand the mic over to Emily, if you'd like to join me. Thanks, Emily.
Thanks so much, Jen. Hi, I'm Emily. My pronouns are she, her. Today, I'll be sharing with you my 2 cents about the topic of lived experience within the report. Currently, I'm a peer worker at Orygen and a lived experience advocate for a few charity organisations. So I was really over the moon that the report had a dedicated, a full chapter to the importance of lived experience. For a bit of background, I think the initial reason why I became so passionate about lived experience was that it was really integral to my personal recovery. I think healing can look really different for everyone, but for me, it was finding out that I wasn't alone. When I was going through everything, I can't tell you how much it helped to hear directly from people that were just like me. Whilst traditional therapies and medications had helped me to an extent, I think the real catalyst in my recovery was finding people who genuinely understood what I was feeling because they had lived it. David will be talking later about the specifics of the lived experience sections, but for now, I'll briefly chat about my thoughts about the two main recommendations in the report regarding lived experience. Recommendation 28 spoke about developing system-wide roles for the full and effective participation of people with lived experience. This detailed things like leadership roles, training opportunities, decreasing stigma, and increasing awareness and understanding of the importance of lived experience. As a peer worker, I feel so lucky to be one of the few lived experience workers in the sector currently. However, a shared sentiment between me and my colleagues at other sites is how unsupported we currently feel as professionals. What often isn't included in the job description of a peer worker is that you're probably going to be the only lived experience professional in your team. This has presented a lot of hurdles, a few of which I'd like to share. As the only lived experience person in your team, you alone have to deal with a stigma from your coworkers about having a mental illness, which could present as people walking around you on eggshells, not trusting you to be stable enough to work, or people not valuing your input, especially in a clinical setting. If you happen to get training, you're really lucky because not only are lived experience workers often forgotten as a part of professional development, there's also a huge lack of training options focused on lived experience. Similarly, there's really unclear career pathways. This is worse for jobs like youth peer workers, where there's an age limit to your job description and you have no idea where you should or can go after your role. I think that's why this recommendation is so important. We need more lived experience workers to make sure our roles aren't tokenistic, siloed, or that we're expected to advocate for basic job rights. We need lived experience leaders, dedicated training, and cultural change sector-wide. And I think this recommendation in this report can definitely help catalyze these much needed changes. Whilst I thought that recommendation 28 was pretty great, I think the report really brought it home with recommendation 29, which called for the establishment of a new agency led by people with lived experience. This agency would be non-governmental and would focus on things like advocacy, training, and lived experience network building across the sector. Sorry. I think establishing a dedicated body of lived experience people will be really invaluable. I'm imagining a utopian agency where I don't have to justify my place in my existence, where I'm preaching to the choir and where lived experience people can build each other up, as well as develop our profession and change the culture in the mental health sector. I really enjoyed the focus of these recommendations and the supporting literature in Chapter 18. However, I would like to point out 3 things I wish the report had focused on a bit more regarding lived experience. Firstly, there was a lack of writing regarding this need for specific shared lived experience. In the case of peer workers, this would be things like having dedicated peer workers with psychosis, peer workers with eating disorders, peer workers that identify as culturally and linguistically diverse, and peer workers that identify as LGBTQIA+. In some circumstances, I think it's really inappropriate to just group all lived experience under one bracket. And I think there's so much value in creating dedicated positions for specific lived experiences, especially for marginalized and minority communities. The second point I'd like to make is, whilst it's great that the report called for more lived experience in leadership roles and on the ground peer workers, I think it should emphasize the need for lived experience at all levels. I mean, can you imagine how amazing it would be to walk into a mental health service and know that the receptionists or the cafe staff had similar lived experience to you? Creating welcoming, safe, and supportive spaces comes naturally after that. It's great that the report called for more lived experience generally, but I think it needs to extend further than just at the top or the bottom organizational charts. Thirdly, I think there could have been a much bigger focus on youth peer work. Adult peer work is comparatively much more of an established career path, whereas youth peer work involves so many unknowns. There's so much debate about things like aging out, salary, supervision, boundaries, and even access to clinical information. In addition to this, there's a paucity of research and training regarding youth peer work. Whilst I think the recommendations are great regarding establishing more lived experience roles and also the lived experience agency, I'm scared that many of these sorts of key decisions may not adequately have a youth voice. I've read the youth sections about the report, and I think there's a really big emphasis on the importance of youth participation generally, but I hope that this isn't forgotten in the lived experience context too. Anyway, thank you so much for coming to my TED Talk / rant. I am really appreciative of your time and patience, and I'll now hand over to Mark from YACVic, who will be talking about stigma and diverse communities.
Hello there. My name is Mark. I use he, him, his pronouns, and I work at YACVic as a peer facilitator. I guess I should also introduce myself in a bit more of a personal way. I am a first-generation migrant from China, and I currently live in Melbourne on Wurundjeri country. And I guess that's the sort of angle that I'm really coming into this with, as a migrant and as someone who, you know, hasn't always lived in Australia, I guess. In terms of thinking about like my culture and mental health isn't really spoken about a lot, or like certainly not in the same way as it might be across Australia. There's a lot more stigma and shame around things like saving face and not disclosing vulnerability to other people and things like that. And I guess that like starting from that point, one thing that I really appreciated about the Royal Commission was how it demonstrated that like experiences with mental ill health are actually unfortunately quite common. And it acknowledged the added impacts and barriers for diverse communities, both in terms of accessing care, but also in terms of how other factors might affect our mental health in the first place. And even though it is unfortunate, I think the Royal Commission really acknowledged what a lot of like individuals in the community have been saying for a really long time. And to have it acknowledged at the kind of highest institutional level in the state is really validating for us, I think. Some of the examples that really stood out to me was the report acknowledging that, for example, the more frequently people experience racism, the more likely they are to have higher levels of psychological distress. It also acknowledged how discrimination can happen inside the mental health system, you know, for example, through culturally unsafe services for First Nations people, or misgendering gender diverse people, or having a lack of trauma-informed care that can actually lead to re-traumatization. So I think the Royal Commission was a really important platform for those experiences to be heard. And it suggests that we can and should talk about mental ill health and the factors that contribute to it more in our communities. At the same time, I think another strength of the Royal Commission was that it didn't kind of put the onus to destigmatize back onto us. For example, recommendation 41, which addresses stigma and discrimination, outlined a bit more of a roadmap of how it should be done, you know, with governments supporting and working in partnership with community-led organizations and community members with lived experience, you know, and it also acknowledged the priority that increased risk groups in diverse communities might have. Another recommendation that really stood out to me in this regard was recommendation 34, which looked at improving accessibility for diverse communities, you know, and making the most of technology, digital technology, to make translation services more accessible so that mental health resources and opportunities can really reach the target communities that need it the most. I think for me, the bottom line is that the system as it was really focused on the kind of crisis point. It was crisis driven, and it didn't really recognize or grapple with the kind of everyday experiences that can contribute to mental ill health, particularly for diverse Victorians. So I guess the overall theme of earlier intervention was really great to see. And sort of my hope for the Royal Commission going forward is that we're able to implement a more triage system, I guess, that has improved crisis end services, but also a wider gamut of like preventative programs around destigmatization as well. Those are sort of my reflections. And I will now hand it back to Reese to carry on with the webinar.
Awesome. Thank you, Mark. And thank you, Emily and Jen as well, for sharing your opinions and thoughts. That's really fantastic. So we'll move on to our last speaker now, who is David Baker. David is the Principal Policy Advisor at Orygen, a role in which he works with the policy team to translate clinical youth mental health research into evidence-informed policy opportunities for government. Today, David will talk about the implementation considerations following the release of the final report. So over to you, David.
G'day, everyone. My name is David and I'm on Wurundjeri land. Thanks to Reese and the YACVic team for this opportunity. It's great to be here, sharing with you all some of Orygen's first steps in responding to the Royal Commission report. This presentation is an overview of an implementation document that should be on the Orygen website by the end of the day. The Royal Commission was upfront in recognising that while the reform agenda is large, the implementation task will be even larger. The Royal Commission was acutely aware of the failures of earlier inquiries to effect lasting reforms. The promise of an inquiry and its recommendations is empty without a plan, will, and resources to implement recommendations. The task of implementing such a far-reaching and detailed reform package was not underestimated. The potential failure points identified highlighted the importance of planning implementation, maintaining political focus and momentum, and sustaining the energy and resourcing the workforce and young people and their families will need to sustain. While collaboration with the mental health sector will be critical to overcoming historical barriers and service divisions, collaboration and with intersecting sectors will also be required. The Royal Commission stated that a willingness to collaborate extends to taking collective responsibility for achieving its reform vision. The Royal Commission has set out a three-wave timeline for its recommendations over the coming 10 years. Foreshadowing the need for a coordinated approach to implementation, the Royal Commission recommended establishing a Mental Health and Wellbeing Commission. This office will be instrumental in managing and reviewing the implementation of reforms. What is now required is the detailed steps needed to achieve the Royal Commission's vision. Orygen has begun to consider how recommendations related to its areas of expertise might be achieved. Without an expanded workforce, many of the reforms the Royal Commission has set out will be difficult to achieve. As such, it recommended that by the end of the year, there would be a workforce strategy, the knowledge and skills and attributes required would be defined, and a mental health, workforce and wellbeing committee would be established. I'll now turn to some of the specific recommendations in the report. The Royal Commission notes that suicide prevention cannot solely be the responsibility of the health sector. It advocated for the Commonwealth and Victorian governments to coordinate a reform of suicide prevention and response services. Training in suicide prevention will be a cornerstone of these efforts. Training programs that are specifically designed to help adults in a range of roles and professions identify and respond to the risk in young people is required. This includes, as was mentioned earlier, school, education, training and employment services, but as well as also social support services for those young people not in education or employment. Training programs designed to help young people help other young people are also required and should also equip them to identify and respond to risk expressed by their peers on online platforms. For most young people, their families, friends and supporters have had to be the stopgap for shortcomings in the mental health system, often to the detriment of their family's own health and well-being. At the same time, families report feeling excluded by the individualistic focus of the mental health system. System-wide involvement of families requires developing a range of roles that enable the involvement of support people across the service spectrum. Demonstrated commitment to inclusion and support roles is required. Family and adult carer-oriented services will not always be appropriate or acceptable for a young person's sibling or siblings. The development of support services and roles for siblings needs to be explored. Overall, a basic suite of services to be offered in each region needs to be determined, with local tailoring of services to respond to demographics specific to each area. The Royal Commission placed a great emphasis on lived experience and the range of roles that they will fill. Differences in youth and adult mental health services require different approaches to supporting the lived experience workforce. The youth lived experience workforce are employed in services designed for young people and need training that reflects this. Dedicated roles rather than a generic lived experience role are required for working with young people. As was referred to earlier, the establishment of a new non-government agency led by people with lived experience will require consideration of a number of potential issues. the agency will need to consider different approaches and representing a diversity of perspectives. The Royal Commission recognised that implementation of digital technology in the delivery of mental health services has faced infrastructure, workforce, and barriers around consumer expectations. Emerging innovations will need to be integrated into the wider mental health service system. Building a contemporary system will require identifying and supporting new evidence-based digital services in a consistent manner to ensure system cohesion while also maintaining scope for implementing technological advancements. It's important that investment in digital technology, research and implementation prioritises emerging blended models of care and workforce capacity in the use of mental health technologies alongside face-to-face practice. There is a lack of consensus about what best practice evidence-based integrated care for young people should comprise when dealing with the co-occurrence with alcohol and other drug use. This is an opportunity for developing innovative, youth-oriented services that consider factors relevant to young people's stage of life and development. Providing both clinical care and practical support will be important in youth services, given the high wellbeing needs of young people with co-occurrence, mental ill health, and substance use issues. The Royal Commission emphasised the importance of innovation and the translation of research into service delivery and evaluation. It will be important to create cultures of clinical research excellence and collaboration with clinical mental health services that will support workforce valuing the importance of utilising and implementing evidence-based clinical practice, but also contributing ideas that will inform further innovative research. A dedicated entity with funding for youth mental health innovation should be given sufficient support for trying out a range of blue sky ideas, encouraging a wide range of innovators to apply. Responsibilities of the Mental Health and Wellbeing Commission will include making recommendations to the Premier in support of implementing reforms and also publishing public progress on reports. This will be informed by evaluation of the implementation of the reform agenda. Evaluation in youth mental health requires multiple stakeholders to inform the evaluation metrics and scope that are applied. These stakeholders should also determine the purpose and scope of data gathered to ensure it meets the needs for research and governance. Incorporating routine evaluation in the implementation of reforms and ongoing decision-making requires bringing together clinicians, young people, families, and researchers to inform future service decisions. Effective monitoring is essential to implementation, playing an important role in maintaining momentum, embedding accountability, ensuring progress, and avoiding unintended consequences, and continually improving reform efforts. If this can be achieved, then many of the pitfalls I outlined earlier may be avoided. The Royal Commission expects the monitoring of implementation to be transparent and independent. Expectations are for a constructive process that supports implementation, not simply a tick and flick exercise. A 10-year reform agenda will need to learn and evolve as implementation progresses.
Awesome. Thank you so much, David, for that presentation. So that concludes the first part of this webinar, which is the presentations, and we'll now move to the questions. We've had a few questions proposed in the Q&A function, and as I said in the chat, we've had 3 answered. So if you go into the Q&A function, the pop-up panel, there should be an option for you to view the answered questions. I'll ask the panelists to now turn on their cameras and be ready to also turn on their microphones when speaking. And just a reminder that when you do speak, please say your name first. So I'll go to the first question, which comes from an anonymous attendee. And the question I'll hand to Viv, which is, will the government put their money where their mouth is and work with primary health networks to give longer term or ongoing contracts to mental health workers, particularly in the youth sector?
Great, thank you, Anonymous. Yep, my name's Vivian Brown. I think that's a really great question. I know that lots of the services that are funded through PHN commissioning have had the experience of very short-term contracts, and that there has been steps to rectify that. So the primary health networks funding is predominantly comes through the federal government, not the Victorian government. So I know that there's been a lot of work done through advocates in mental health services to the federal government to try and get longer contracts and agreements in place through primary health networks to make sure that, as you said, addressing those issues of workforce retention, giving people security, and also people in the community accessing those services, some continuity of care too. So yep. Hope that helps answer it. Thanks, Reese.
Awesome. Thanks, Viv. The next one, we have agreed in the background to also hand this one to you, Viv. It comes from Angus, and the question is a bit of a forward-thinking one, but any plans to advocate for these changes at a federal level? We would love them in New South Wales.
That's also a really great question. Thank you. Look, I know that the Executive Director at Orygen, Pat McGorry, has talked about this publicly, so I feel confident that I can say it. But a couple of weeks ago, we met with the Prime Minister talking about mental health reforms and talking about the Royal Commission. And we certainly had assurances and feel confident that he expressed that the relationship with the Premier is very strong on these issues, that they are very confident that they will have a really good plan moving forward with Victoria as the first cab off the rank in developing up a national partnership agreement around mental health funding, and that they're looking for that partnership agreement with Victoria to then become the template for other states and territories to follow. So again, hope that answers your question, but I think given how good things are in terms of the commitment of both the Premier and the Prime Minister to the Victorian agreement, that we should be in a good place to be able to influence change in other states and territories too.
Awesome. Thanks, Viv. I might just jump around a bit in terms of the questions so we hear from others. And I'll hand this one to Julia. And this question comes from Catherine, and it says, I'm wondering how the main themes and concerns listed in the report reflect in educational school settings, and how the recommendations address this to support mental health promotion, prevention, and support. As an example, are there recommendations focus on how lived experience and peer work can support schools to focus on mental health?
Thanks, Reese and Catherine. That's a fantastic question. It's Julia speaking here. In short, there's no specific recommendation around lived experience workers and peer support workers in education settings specifically. However, recommendation 28 talks about developing system-wide roles for lived experience, and the inference within those recommendations is that it would be to promote the roles of lived experience and peer support workers across all settings, and ensure that that is kind of implemented and developed. Recommendation 17, which is around supporting social and emotional wellbeing in schools, does talk about evidence-informed initiatives, including anti-stigma and anti-bullying programs and developing digital platforms. And so I think within that, again, whilst there's nothing specific around lived experience, I think it's safe to assume that that would definitely be considered when developing these programs. And given the way the chapter reads and the emphasis that's put on lived experience, I would think that there would be some emphasis put on that within schools, and especially around young people in schools with lived experience and promoting their roles in supporting each other within the school programs.
Awesome. Thanks, Julia. Where am I up to? I'll ask this question to Luke, and it comes from Victoria. The question is, when will a full mapping of all community-based, not-for-profit organisations take place that support youth mental health and wellbeing, rather than a continued focus on recognised organisations?
Thanks for the question, and thanks, Reese. Luke speaking. I should say that the Commission did highlight some mapping work, particularly around local government in Volume 2. They've recommended that the Municipal Association oversee the development of user-centric and accessible local digital community directives. I am quoting there, I'm not using that language. They've said that those directories will advertise local community initiatives to be used by local community members and the new community collectives, as well as the local mental health wellbeing services. So the idea there is they're going to do some specific work around creating directories for each of the local government areas. I should also say that, as Viv had foreshadowed, while Headspace services might take on those role of local youth mental health and wellbeing services, there is an intention to look to other organisations to deliver those. And it does seem, in reading through the report, that there is a greater emphasis on community services and not just existing mental health services.
Awesome. Thanks, Luke. I'll move to a question directed for Emily. And that question is, what was your experience moving from the patient side to treatment side? And how would you like to see more lived experience persons become involved as workers with young people, peer support and therapists, or even as receptionists and others of our organisations?
Thanks so much. What was it like for me moving from patient side to treatment side? Sorry, Emily speaking. Really difficult, honestly. I think it takes a certain amount of, for me, like passing a certain threshold of wellness, if that makes sense. And I think you're sort of expected to have that when you're within at least the current mental health sector. And that's a really hard line to keep past, because I feel like, yeah, recovery is very nonlinear, and like I have my ups and downs, and I think I sort of feel pressured to still be on the like treatment side rather than the patient side, but I don't think there's really like a clear delineation, if that makes sense. Like I'm still recovering, and I think I always will be, and I think that that's something that's really important about lived experience, is that we're each on our own recovery journeys, and you don't really cross a barrier, so to speak. Like you're in tandem, you're walking with the people that you're working with, and I think that that's really powerful. But as for like what it takes to like have more lived experience workers within organizations, I think it's not just that personal change that each of us lived experience workers have to go through. It's also, I think there's a huge amount on the organizational side. And so that's around like building cultural readiness, and having protected spaces, as well as decreasing stigma and building an understanding of the importance of lived experience. Because I think I don't want to talk too much crap, sorry. But I think a lot of people can be scared of working with people with experience. Like I've had people that have been scared of like triggering me, or like, I don't know, like talking certain topics or certain ways. And like, I don't want people to be scared of working with me. I want to be treated as an equal. I don't want to have to feel like I have to justify my place within a team. Yeah, and I think it's about building that sort of culture within organizations to allow for lived experience people to feel as equals, and like, I don't know, like just take up the space that they were employed to take up. So I think, yeah, as I spoke earlier, I think this can be enacted on all sorts of levels. So receptionists, team leaders, like it doesn't have to be a peer-to-peer level to be a lived experience worker. You can be a policy analyst or a researcher and have lived experience, but having those sorts of protected spaces, I don't know, it makes a real big game changer, I reckon, in the mental health sector. And I think that that's something that's, I'm very passionate about it, if you can't tell. But thank you so much for the question.
Thank you, Emily. I'll move to a question from Bridie, which I will direct to Jen. And the question goes, sorry if I missed it, how will the recommendations support young people in rural areas? Not all digital, I hope.
Jen speaking. Yeah, great question. I also hope it's not all digital, because I totally understand where you're coming from there with lagging Zooms and lagging Teams meetings. It's not all digital. Luke, please feel free to jump in here, because I know you briefly touched on it a little bit earlier before, but there will be recommendation 4. We'll see the creation of 8 regional mental health and wellbeing boards who will commission mental health and wellbeing services in rural areas. Recommendation 39 does speak to those 2 new digital service delivery initiatives, which will hopefully be trialled by the end of 2022. But then there's also recommendation 40, which talks about providing incentives for the mental health and wellbeing workforce in rural and regional areas. And the Royal Commission recommends there that the Victorian government addresses the mental health and wellbeing workforce supply needs in rural and regional areas and establishes an incentive scheme to attract mental health and wellbeing workers to these areas and retain mental health and wellbeing workers in these services and these areas. Was there anything I missed there, Luke? I know you touched on it briefly earlier as well.
Luke speaking. No, that's perfect, Jen.
Cool. I hope that answered your question. Thanks.
Awesome. Thank you, Jen. I will hand 2 questions to David, but I'll ask them one at a time, obviously. The first one comes from Willow, and they ask, it was mentioned that it will take time for these recommendations to be implemented into the mental health system. Do we know what recommendations will be implemented first?
David speaking, and thanks, Willow, for your question. It's a really critical question, and you have to go all the way to volume 5, the last one, to answer it. It doesn't prioritise any of the policy recommendations, although workforce does have a number of deliverables by the end of this year, given it's so critical. But there's a table set out over about 6 pages that has a timeline of short, medium or long for different aspects of each of the policy recommendations or reform recommendations. So they haven't prioritised any one area over another, but within each recommendation, there are important things to be done first and then a staggered implementation.
Awesome. Thanks, David. And the other one that I'm going to ask you, David, comes from Colin, who is calling from Perth. And they ask, what does the report say about the issue of housing and accommodation for young people with mental health issues and for young people who live in precarious housing or who are homeless or at risk of homelessness?
Yeah, thanks, Colin, for that question. It was one of the slides I was going to present, but I dropped it at the last minute as I was running out of time. But it is an important issue, and I'm glad you've asked a question. The Royal Commission recognised that for young people, a stable home can bring a sense of safety, security and belonging, all of which are fundamental to their well-being and mental health. Their recommendation focused on supported housing, and it's important that configurations of housing reflect the needs and living arrangements that work for young people. So for some young people, that will require sort of family-like figures, but for other young people, it'll be peers. And so it's important that the configuration of these housing opportunities are co-developed with young people. And the Royal Commission also recommended that existing policies that the Victorian government have on building social housing be overlaid with a mental health support lens, so that this new social housing will ensure that it delivers the needs of young people and all people with experiences of mental ill health.
Thank you, David. So just looking at timing, I may only be able to ask 2 more questions, so I'm very sorry for the 5 that are in there. I will move to the one at the top of the list, sorry for that notification, which I will ask to Viv. And it says, are there any insights into the way these recommendations will impact the higher education system in terms of accessibility to tertiary education? It is great that education settings will expand mental health supports, but I guess with these major changes, we will need more professionals. I do see access to education as a major barrier, particularly in terms of access to further ed, recruitment and retention of qualified professionals in rural and remote areas. Your thoughts?
Thanks. So it's Viv here. That's look, the report does talk a bit about higher education settings. It talks about universities and vet providers as well. From my read of the report at this point in time, they point to the National University Mental Health Framework that's been developed by Orygen and make a point that they support its implementation into university settings. Now, that framework itself is incredibly broad, covers everything across from sort of supporting wellbeing and healthy learning environments right through to responses of universities for students who are experiencing psychological distress or mental health issues while they're studying. So I guess it's sort of a point to go back to that university framework, and we're still doing work here at Orygen too to see how we can support universities to implement that. But yes, absolutely, having a skilled and a capable and an adequate workforce to meet demand for mental health supports in these settings is critical.
Thank you, Viv. I will ask one more, and it will be our last one, and I'll hand it to Julia. And the question comes from Catherine, and it is, was there any recommendations regarding disability, young people and mental health, i.e. specified training, supports, resourcing and centres?
Thank you, Julia speaking. So really, unfortunately, in regards to recommendations for disabled people and culturally diverse communities and LGBTQIA+ people, they were all really grouped together under recommendation 34 and when referencing diverse communities. So there's actually nothing specific under that recommendation around that level of support other than ensuring all services are accessible and inclusive in that way. Volume 2, I believe it is, does have a chapter around that. And so there is a little bit more detail, but in terms of specific recommendations, there's nothing that goes into more detail other than what I spoke about earlier around support for disabled people.
Awesome. Thank you, Julia. A lot of our panelists are taking their time to type answers to some of the questions. I might ask whoever is hosting this meeting, which I think is Luke and Andrew, but I'm not sure. Perhaps they can send out the written answers to everyone so everyone can access them and read them in their own time. So that brings us to the end of our webinar. I would like to thank all of the panelists for joining us, and I would like to thank all of the attendees for having some really vibrant discussions in the chat and asking some really fantastic questions. I understand that some of the content we've covered today may have been distressing or could make you feel uncomfortable or you need to talk to someone. And Andrew has put in some important links and phone numbers to some organisations that you can call to access some support. So I'd like to thank you all again. There will be some follow-up emails and have a great day. It's lunchtime, so I'm going to eat lunch.